In this video, we'll be looking at the final concepts in pharmacokinetics, and we'll be focusing on elimination processes. Here are the learning outcomes that we'll cover during this video. Now, if we look at elimination itself, it's a summation of two main processes. One is the metabolism of the drug, which is the biotransformation, so chemical changing of the drug by a series of enzymes, and usually in the liver. The second process is excretion. So this is the irreversible removal of the drug from the body, and this occurs mainly through filtration into the urine via the kidney. Now, the elimination rate, so the speed at which the drug is removed, is influenced by the plasma concentration, so how much drug is available for elimination, and clearance. Now, clearance is actually a measure of the efficiency of the elimination of drug from plasma. So therefore, the elimination rate is based on how much drug you have available, which can be influenced by the volume of distribution. So is the drug mainly in the plasma, or has it extensively moved into the tissue space, and therefore it's not as available in the plasma? And the efficiency of the processes that remove it. So that would be the ability for the liver to extract and metabolize the drug, or for the kidney to remove the drug physically from the plasma itself. Now we'll look at these two processes in turn. So we'll start with metabolism. Now, as I've already mentioned, the principal site of metabolism is in the liver, and the cytochrome P450 enzyme family is the main set of enzymes responsible for the biotransformation of drugs. Now, the metabolism is not restricted to the liver. It can happen in all cells to a small extent. A good example of that is in the gastrointestinal tract, which actually expresses a number of these cytochrome enzymes. Now, the outcome of the biotransformation really depends on the drug, but there are a good set that are common or more likely to occur. The first one is that usually the drug after the biotransformation event actually becomes more water soluble, and in becoming more water soluble, the drug is more likely to be able to be removed physically from the body, usually by the renal, but also through bile can also occur. Now, often what will happen during the biotransformation is the drug activity will decrease, so the drug becomes less active. Now, sometimes the metabolite actually may be more active, and this is probably more pronounced when the drug is actually a prodrug. So the prodrug actually has very limited activity, and it requires activation to actually become therapeutically useful. Now, there are a couple of different phases of metabolism, and really it's the separation of two different types of reactions. It's not that one has to occur before the other. They can occur independently of each other, or both of them may affect the drug during its metabolic kind of pathway. So phase 1 reactions are generally simple. They may be oxidation reduction, so from the first enzyme family, or it might be a hydrolase reaction where it kind of breaks the molecule apart, usually at an ester group, or it might be the removal of an active group, like a carboxyl or an amine group from the drug molecule. Now, phase 2 reactions are a little bit different. Often these are conjugations, so like the transferases, which are EC2 family, they move one molecule and attach it to the drug molecule. The real classic example here is the movement of glucuronic acid, or the conjugation of glucuronic acid with the drug. And now what we'll do is we'll have a look at an example of this. So we'll take aspirin as an example. So we've got the structure of aspirin with its aromatic group, an acetyl group, and a carboxyl group. And what happens in phase 1 is hydrolysis. It will break apart that ester bond and release the acetyl group. Now that's an example of a phase 1 reaction. And sometimes what a phase 1 reaction will do is it will create a handle for a phase 2 reaction. And so in this example, we've got a conjugation phase 2 example where we have the glucuronic acid being added onto the aspirin or the salicylic acid group now. And so this is done by an enzyme called UDP, glucuronyl transferase. So it moves that glucuronic acid and attaches it to the aspirin or the salicylic acid molecule now. And you can see that there are a number of water attachment points now. Because the glucuronic acid has lots of hydroxyl groups, water can now interact with it. So now what happens is aspirin, which was fairly insoluble, is now much more water soluble with the addition of that conjugated group. Here is a list of the cytochrome P450 superfamily. Now you notice that cytochrome enzymes actually play a lot of different roles in the body, from the synthesis of cholesterols to the management of xenobiotics, working with fatty acids, eicosanoids, synthesizing vitamins, and there are a few that are put into the unknown basket. So they do other physiological roles. Now, the ones that I've highlighted are the ones that you're most likely to see interacting with drugs and metabolizing drugs. So if we have a look at those in turn, what you'll find is that each cytochrome enzyme reacts with a different set of drugs. Now, I've just got a few different examples listed here, but the list is actually quite extensive for each one of these. Now, the largest kind of grouping of drugs, or the enzyme that is most important, is actually CYP3A4, and it's the one that you'll see the most drugs under that particular list when you go and have a look at the full list. Now, the first column is just a set of examples of drug substrates that are metabolized and biotransformed by that cytochrome enzyme. The second column is a set of drugs that act as inhibitors. And so if someone is taking an inhibitor of that particular cytochrome, the substrates get metabolized at a much slower rate. So this is an inhibitor of an enzyme. So erythromycin is an example, a classic example of a CYP inhibitor, and it's an antibiotic that could be used. You'll also notice that grapefruit juice is also an inhibitor of the cytochrome 3A4 family. So this actually becomes an important drug interaction that can occur through this cytochrome family. The final column is a list of inducers. Now, inducers, what they do is when they're given to a patient, they will stimulate the expression of specific cytochrome families or cytochrome enzymes. So if we look here, we've got cigarettes. So the polyaromatic or polycyclic aromatics that are in cigarettes stimulate the expression of CYP1A2. What this means is that there is more enzyme available, and therefore the substrate will be metabolized at a faster rate, and there will be less of it available to act. And so you can see that there are a number of inducers that are in that column. So cigarettes being one, drugs that are used for the treatment of tuberculosis are other examples, carbamazepine, which is an anti-epileptic drug, alcohol itself metabolizes or induces its own metabolism, as does carbamazepine. And the final one that I'll just point out, because it's one to watch out for, is St. John's wort. So this is a complementary and alternative medicine that can be self-prescribed for the treatment of depression, and it acts as an inducer for the CYP3A4 family, which of course is the family that metabolizes the most number of drugs. So it actually has a number of drug interactions that are possible. Now, if we move on to the next part of elimination, which is excretion. Now, the main organ involved in excretion is the renal, so it's managed by the kidneys. A secondary route of excretion is through the bile duct. And so what will happen is the metabolites or the drug itself is put into the bile, and then that is excreted into the small intestine and eventually passes out with the rest of the fecal mass. Drugs can also go via other routes, but these are very minor in comparison to the previous two. So it can go out through sweat and perspiration, or whichever one you like. Respiration, so particularly gas anesthetics will go out via respiration. Alcohol or ethanol is another example of a drug that will come out through the respiration, which is why we have random breath testing. It can also come out through tears, and it's also possible to come out through breast milk as well, which can affect the child that is ingesting the breast milk. So as mentioned previously, excretion is the irreversible removal of drug from the body. And if we're just looking at the kidney, there are three main processes that are involved in the amount of removal of the drug. So the first one is glomerular filtration. So the arrangement of cells and the blood flow through the glomerulus allows drugs, particularly small drugs, to be filtered straight out from the blood and into the urine. Now, generally what you'll observe is drugs that are dependent on this process will exhibit first order kinetics. So the more drug that is present, the more drug you'll be able to get rid of. Now, the second point or second area of elimination is you can have active tubular secretion. And so what you see in this area is you have non-selective carriers, so transporters that are in the proximal tubule that will pump drug from the blood into the cells lining the nephron, and then from the nephron cells into the lumen, into the urine. And so there are organic anion transporters and organic cation transporters that will move acids and bases respectively into the urine. There are also other enzyme transporters that are involved in this process. The third point I'll bring up here is tubular reabsorption. So not only can drugs go into the urine, but they can also be reclaimed. So this could be due to the lipophilicity of the drug, so just reabsorbing, and particularly because the urine becomes concentrated, particularly when you get to the distal tubule, you might get more drive for the drug to return into the body. The other thing that can change reabsorption rates is the urinary pH. So as the urine becomes concentrated, its pH usually drops, and that can also affect the ionization state of the drug and therefore its reabsorption probability. Also, the flow of the urine through the nephron can also influence. So a slower flow will increase absorption rates. So if we have a look at that in the nephron itself, the glomerulus itself here in the Bowman's capsule is where the blood and the drug in the blood is going to be introduced into that filtration process. And essentially what we're going to see is the drug moving through the pores and into the urine, the filtrate itself. If we have a look at the proximal tubule where tubular secretion can occur, you can see the organic anion transporters and cation transporters, and PGP, which is a multi-drug transporter, can move drug into the urine and eliminate or excrete the drug via that process. And tubular reabsorption can use similar processes. So they can be transporters there, but it can also be possibly through lipophilic processes as well. And finally, we'll look at various different aspects that can be influenced by individual variation. So every patient that you'll see will respond differently to drugs and will have different processes or variations in the processes. So genetics is one area where there will be a lot of variation introduced into the pharmacokinetic profile of a drug in a patient. So genetics can affect how well a transporter works and what it recognizes. There are changes to enzyme function, so you can actually have enzymes that are actually not expressed in patients at all, or you might have twice as many
of those enzymes expressed, or it just may not be as an efficient enzyme because of genetic variation. Age can also affect pharmacokinetic processes. So in the very young, so neonates, the gastrointestinal tract and the kidneys just haven't formed completely yet. And so there's this stage where those absorption processes and excretion process and metabolism processes are just not well developed. So there's a potential for greater exposure in the very young to a drug, and so a lot of dose alterations are required. In the elderly, the kind of reverse of that is happening, is that the kidneys are actually starting to degrade, and so their functionality is lost, and so you're more likely to accumulate a drug unless you reduce the dose. Weight can also play a factor, so whether somebody has a lean body mass or an obese body mass, this will change the water to fat ratio and therefore can change the distribution of drugs through a body. There are pathophysiological conditions that can affect liver function and therefore the metabolism of drugs, and also the kidney can also fail, and therefore the excretion, the physical removal of drugs can also be affected. And finally, the number of medications and the types of medications can all interact. So we can have drug inhibition rates that are changed, and we can also have drug induction, which will increase the metabolism of drugs and therefore make them less active. Whereas the inhibition is more likely to make a drug more active. And so therefore, in either one of those situations, a drug dose may need to be altered, either up or down, depending on whether you're working with inhibitors or inducers as the point of drug interaction. Okay, back to the learning outcomes. So you should be able to outline possible outcomes of drug metabolism. So example, water solubility or the activity of the drug. You should be able to identify different phases of drug metabolism, so phase 1 versus phase 2. You should be able to differentiate the impacts of induction and inhibition on the function of cytochrome enzymes, so slowing down metabolism or increasing metabolism. Should be able to outline the key features of renal excretion, so the filtration versus secretion versus absorption, and differentiate elimination from excretion. Should be able to define what drug clearance is actually referring to and how it's different from elimination, and identify processes that are subject to individual variation. So the genetics, the age, the weight of the patient, the medication that they're taking. So all of these things can factor into how a drug may behave differently in different patients.